Welcome to our video on meningitis. Let's get started. We will discuss the definition of meningitis, as well as the etiology, clinical features, highlighted cases. So, for example, the types of infections that can cause meningitis. Then we're going to talk about the diagnosis and how you manage it. Now, meningitis is defined as inflammation of leptomeninges that surround the brain and spinal cord. So here's an image that shows explicitly those layers of the meninges. So just as a brief anatomy review, we've got the dura mater, the arachnoid mater, and then deep to that is the pia mater. All of that surrounds the brain tissue. So when we say that the patient has meningitis, then we're including these layers as well as the CSF. So the leptomeninges. Now, meningitis is commonly caused by bacterial pathogens. Streptococcus pneumoniae is the most common pathogen of community-acquired bacterial meningitis. Neisseria meningitidis is the most common pathogen of bacterial meningitis in children and young adults. And other common ones to know are H. flu and listeria. So if you're just thinking in general terms, strep pneumo is the most common. Now, meningitis can also be caused by mycobacterial pathogens, such as Mycobacterium tuberculosis. It can also be caused by viral pathogens, such as enteroviruses, and fungal pathogens such as Cryptococcus neoformans. So now let's move on to the clinical features. So the classic triad of meningitis is fever, nuchal rigidity, and mental status changes. However, there are also some other common symptoms, such as headache, nausea, vomiting, and photophobia. On physical exam, you should be able to elicit a Kernig or Brudzinski sign. So here's an image showing the Kernig sign. When the patient lies flat and the hip and knee are flexed in a 90-degree angle. They're extending the lower leg slowly. So you look at that physician's hand, trying to slowly lower the leg. That produces pain and resistance. So in this image, note the contractures of those hamstring muscles. There's also that retraction of the head. Also notice the expression of suffering that's produced by that examiner's effort to extend the lower leg. So basically, as he tries to extend that knee joint, then it's producing a lot of pain. Now here's a sketch showing the Brudzinski sign. Now when the patient lies flat, then you can take the neck and try to passively flex it. So you're pushing their head forward. The sign is considered positive if you pushing the head forward like that causes the hips and knees of the patient to voluntarily come forward and flex as well. And I say voluntarily as in you're not doing it. You just see that it happens because all you're touching is the head. Now, before we move on to diagnosis, we'll discuss some highlighted cases of meningitis. Let's start with meningococcal meningitis. So the responsible pathogen here is Neisseria meningitidis. And this has an acute onset. And the characteristic features that may help differentiate this from other illnesses are severe myalgias and non-suppurative pharyngitis. And that rapidly progresses within 12 hours. Now, on physical exam, a petechial or hemorrhagic rash is characteristic. You can also see pale and mottled skin. So again, this is helping you distinguish meningococcal meningitis from other types. Now, what are some of the complications of meningococcal meningitis? Well, this can be shock, and that's possible with any type of meningitis. You can also get DIC and Waterhouse-Friderichsen syndrome. You may recall from your studies in the preclinical years that Waterhouse-Friderichsen syndrome, the patient will have an acute adrenal insufficiency secondary to bilateral adrenal hemorrhage. And that's something you attribute specifically to the meningococcal meningitis, not common to other types of meningitis. Now let's do a question to apply what you've learned so far. A patient is rushed to the emergency department due to the sudden onset of hypotension, hyponatremia, hyperkalemia, hypoglycemia, and metabolic acidosis. The patient admits to experiencing a fever and neck stiffness over the last few days. What would the organism causing this patient's condition look like under the microscope? Now feel free to pause the video as you consider the question. Okay, so this patient presents with a sudden onset of hypotension, hyponatremia, hyperkalemia, hypoglycemia, and metabolic acidosis. Now this constellation of symptoms should make you think of an acute adrenal crisis. Now the patient has also experienced fever and neck stiffness, which, along with those mental status changes, is the classic triad of meningitis. So you're thinking meningitis and an acute adrenal crisis. And what's the name of an acute adrenal crisis that's brought on by a serious bacterial infection? It's Waterhouse-Friderichsen syndrome. And in this circumstance, we're attributing that to a disseminated Neisseria meningitidis infection, causing meningitis in this case. So if you're looking at Neisseria meningitidis under the microscope, what will you see? Well, you'd see gram-negative diplococci. Now here's an image of a gram stain of CSF in a patient with meningococcal meningitis. And here you can see that gram-negative diplococci. And if you'd like a review on any of the microorganisms, including Neisseria meningitidis, please feel free to view our microbiology mnemonics in our Step 1 library. Let's talk more about the clinical features. So here's that petechiae. So that's a classic finding in meningococcal meningitis. There's also purpura here. So if I were to tell you that the patient that this image was taken from is a patient demonstrating signs of meningitis, then you'd think, okay, it's possibly meningococcal meningitis because of the petechiae and purpura. Let's also discuss cryptococcal meningoencephalitis. So this is an opportunistic infection caused by Cryptococcus neoformans, which is an encapsulated yeast. It most commonly affects HIV patients with CD4 counts less than 100, and it has subacute onset. So instead of being like rapidly within 12 hours like Neisseria meningitidis, this one actually occurs over 1 to 2 weeks. And the patient usually presents with a fever, headache, and malaise. So pretty common meningitis symptoms. Now there may be evidence of elevated intracranial pressure, such as papilledema seen on fundoscopy, and there may even be a cranial nerve 6 deficit. And you may recall from anatomy and physiology that if a patient has an abducens nerve deficit, then they're going to have a lateral gaze palsy, and they're going to complain of double vision, or that diplopia, because they don't have a conjugate gaze. Now what's interesting in these patients is that you're not really going to see photophobia and nuchal rigidity. That's usually absent. And if you're looking at the skin, you may be able to identify umbilicated skin lesions, and that would represent disseminated disease. Moving on to tuberculosis meningitis. The responsible pathogen here is Mycobacterium tuberculosis. And here, just like the last one, cryptococcal meningoencephalitis, the onset is subacute. And the patient can present with fever, a headache, and nuchal rigidity, which you would expect. Now, confusion and cranial nerve palsies, particularly of cranial nerves 2 and 6, are common features as well. And then seizures and a coma can ensue in later stages. Also, hydrocephalus is a common complication of this type of meningitis. And this is due to the typical occurrence of basal meningitis and obstruction of the basilar cisterns. So the key takeaway here is to think of tuberculosis meningitis as commonly blocking the flow of CSF. So naturally, there's going to be increased intracranial pressure here. Now here's an amazing algorithm I'm going to walk you through. But before I go any further, I want to attribute this to Amboss. So thanks to them, we can talk through this and help you get a great idea of how you should be thinking about these symptoms. Okay, so when suspecting meningitis, for example, a patient presenting with a headache, fever, and nuchal rigidity, then your goal is to start empiric therapy as soon as possible. However, it's important to begin by establishing that IV access. You're going to also give oxygen, especially if there's respiratory distress, and then also get some blood labs to be sent for cultures. And you're also going to be evaluating for glucose, white blood cell count, and coagulation studies. So hopefully it's apparent to you that if the patient is unstable, you need to address that first. So what do? Well, you can give intravenous crystalloid, particularly if the patient is hypotensive. So you're thinking they're in shock now, septic shock. And then of course, ABCs, you're going to look at the airway and make sure that they're protecting their airway. And why would you be thinking of them not protecting their airway? Well, that's because oftentimes these microbes can cause altered mental status. Okay, now if there are seizures present, then of course you're going to address those. And now once labs come back and you see any abnormalities in the coagulation panel, then you're going to address that quickly, particularly if the patient has signs of DIC. So what would that look like clinically? Well, you're going to see bleeding from multiple sites in the body. Okay, so you're stabilize the patient. Next, you're going to evaluate for the presence of any alarm symptoms. So what are these alarm symptoms you're expecting in meningitis? Well, there could be focal neurologic deficits, altered mental status, and if the patient is immunocompromised, that in and of itself is an alarm symptom in the context of meningitis. If there's any evidence of increased intracranial pressure, you might see this on fundoscopy by seeing papilledema. Another alarm symptom would be lesions near the lumbar puncture site. And then, of course, any seizures. So how can you remember all those things? Well, there's actually a helpful FAILS mnemonic, F-A-I-L-S. Okay, so let's say they don't have those. That means that you're actually able to safely proceed with a lumbar puncture. And what you do with the CSF that you get from the lumbar puncture, you're going to send that out for a cell count and differential. So you want to see what types of cells are there. Basically, are there neutrophils that are high, or are they lymphocytes that are high? You also want to know the glucose concentration and the protein concentration. Okay, so now you've extracted that CSF for sampling. You're able to study it now. At this point, you're able to give empiric therapy because you're not worried about your antibiotics disrupting or altering the outcome of the study because you've already obtained it. Okay, so what is that empiric therapy? Ceftriaxone and vancomycin. And you should also add dexamethasone if you suspect pneumococcal meningitis in adults, or in the case of a child, if you're considering Haemophilus meningitis. So in those two circumstances, also add dexamethasone. But what if the patient is above 50 years old or they're immunocompromised? Well, in those cases, you're actually going to add ampicillin. And the reason for that is because these patients are often at risk of listeria, and ampicillin will cover it. So if they're immunocompromised or above 50, give ampicillin. So you've started your patient on this empiric therapy, and then the CSF analysis comes back and it's normal. However, the CSF cultures are not back yet. So you're going to continue that empiric therapy until their cultures are also negative. And at that point, of course, you're not worried about an infection, so you can discontinue your empiric therapy. But what if that CSF comes back and it's abnormal with a white blood cell count above 1,000 and it's predominantly neutrophils, and the glucose is below 40 and the protein is above 250? What should you think there? Well, at this point, you're going to be thankful that you've started your empiric therapy because this is highly suggestive of bacterial meningitis. So here's a picture of a CSF sample. Notice that gross appearance. It's cloudy and purulent. This is actually typically seen in bacterial infection. Now, what if the white blood cell count is below 500 and it's predominantly lymphocytes, and the glucose is normal to low, so not super impressive, and the protein is above 250? What category of pathogen are you thinking about there? You're thinking about fungal meningitis. Now, what if the white blood cell count comes back and it's somewhere between 5 and 1,000? So not super helpful because that could be fungal or bacterial at this point. It's not great information yet, but it's got a predominance of lymphocytes, but the glucose is below 5 and the protein is above 250. So here you're thinking tuberculosis meningitis. Now, in these three cases, you actually need to do further workup, such as gram stain, acid-fast stain, India ink stain, fungal antigen, PCR, cultures, and sensitivity. And you'd, of course, adjust accordingly. So the idea is that you don't know the exact organism when you send the CSF off for being studied. But once it comes back and it kind of implicates either fungal, bacterial, or mycobacterial, like tuberculosis, then you're going to order further things to test that CSF. Because it wouldn't make sense to do a gram stain until you've got to that point. But once you do have a better idea, go further. And then, of course, you can tailor that empiric therapy to more targeted therapy. So let's note that if the responsible pathogen for bacterial meningitis is Neisseria meningitidis or Haemophilus influenza B, then post-exposure prophylaxis for close contacts of your patient should be provided. So if the close contacts of your patient are adults, then you're going to give rifampin, ceftriaxone, or ciprofloxacin. And if the close contact is pregnant, then you're going to give those contacts ceftriaxone. And then in the case of minors, you can either give rifampin or ceftriaxone. Also, if the patient is presenting with a non-blanching rash, then meningococcal meningitis or Rocky Mountain spotted fever should be suspected. However, if CSF analysis is not compatible with meningococcal meningitis, then you're going to kind of push the Neisseria meningitidis out of your mind, and you're going to focus more on Rocky Mountain spotted fever. And what type of thing do you want to ask about with somebody who may have Rocky Mountain spotted fever? You're going to try to find a history of tick exposure. Okay, so if you're thinking it's Rocky Mountain spotted fever, you can give doxycycline. So you're going to add that. Of course, that's just empiric. You don't know that it's Rocky Mountain spotted fever yet. So you're going to need to do further workup, such as serology, PCR, and skin biopsy. Okay, let's go back to the CSF analysis results one more time. So if the white blood cell count is between 100 and 1,000, with predominance of lymphocytes, and the glucose is between 40 and 70, and the protein is low, this is when you're thinking about viral meningitis. So you've treated your patient empirically with antibiotics, which was smart. The CSF comes back. This is predominantly lymphocytes. The glucose is in this range and the protein isn't super high. I'm now thinking it's viral. So what do you do next? Well, you stop those antibiotics. You're not worried about that anymore. And actually, you're going to give them supportive therapy. Now, one thing to be extremely aware of is signs of HSV encephalitis. So those would be altered mental status, which is common in any type of meningitis. Also anosmia, or if when the lumbar puncture was first performed, there was blood, so you call that a bloody tap, or if there's temporal lobe involvement on an MRI. So if you see any of those things, alarms should be going off and you think, okay, I need to give IV acyclovir to cover for possible HSV. In fact, a lot of doctors just give acyclovir, even empirically, or even when they know that it's viral but don't know specifically that it's HSV. So we did this entire discussion assuming that the patient could get a lumbar puncture and it was not contraindicated. But what if in that fails mnemonic, they did have some of those positive signs, those alarm symptoms that made a lumbar puncture contraindicated? What do you do then for your patient? Well, the next step is just assume empiric therapy. Just give antibiotics like we mentioned before. You're also going to get a head CT. And on that head CT, you can look for signs of elevated intracranial pressure. And if there's no signs of that, then at that point you're thinking, I'm not as worried about the alarm symptoms. Again, that fails mnemonic. So you're actually probably fine giving a lumbar puncture. In fact, at this point, it's what you should do. It's essential. And then you send the CSF off for analysis, and then you do what we've described on the previous slides. But what if when you do that head CT, it shows signs of elevated intracranial pressure? Well, in that circumstance, you're going to be really thankful that you didn't jump the gun and give a lumbar puncture because you were safe and took care of your patient and you noticed those alarm symptoms were present. And now you just confirmed it on imaging. So at this point, you think, okay, a lumbar puncture is out of the question. We're not going to do that. So you're going to continue the empiric therapy that you gave. And until you get more information about what the specific pathogen is, you're going to continue it as empiric. And if you do get more details about the correct pathogen, for example, in the form of blood culture, then you can adjust accordingly. But what if the CT comes back and you get this curveball and you see a ring-enhancing lesion? So at this point, you're thinking, maybe they've got something totally different. So what things do you think about when you see a ring-enhancing lesion on a CT? Well, there's 3 big things you want to think about: toxoplasmosis, a brain abscess, or a CNS lymphoma. And those ideas will be discussed later, but just keep that in the back of your mind. You've got this patient who's feeling sick, they're altered, things don't feel right, you were thinking meningitis, you do the CT, and you see a ring-enhancing lesion. And you're thinking, oh, these 3 things: toxo, abscess, lymphoma.